Thank you. This has been very interesting for me to listen over the past, okay, that works. Can you hear me? Is that close enough? Over the past couple of days, I've been on both sides of the table, but I'm here as a patient, and is that better? Okay. So I guess one of the things that I've noticed over the past couple of days is where's the patient? And some of you may recognize this. This is the Where's the Beef commercial. There's been some patient, but it's been very small. And I think that, I even felt uncomfortable. I was kind of jealous because the medical students got to ask questions. And as the token patient representative, I didn't. I got to listen, and I am getting to speak now, and they're not, and I understand that. But I kind of had some questions along the way that I would have liked to have asked. But I just sat quietly until today. So I think that patients need to be a part of this discussion. Somebody called this an iterative process, and patients need to be a part of an iterative process if the ultimate goal of what all health professionals do is to treat patients. And you can't treat patients the way you want to treat them. You have to treat patients the way they want to be treated. Medical students, they did a great job, but patients need to be a part of this as well. And I think that in the real world, they are, and that's something that you need to consider. Somebody brought up in my group, and I served for 14 months on the negotiated rulemaking committee for redefining medically underserved populations and HPSAs, which is all about federally qualified health centers. Federally qualified health centers have to have 51% of their board members as patients. Under the Affordable Care Act, which is our health care law, if you want to maintain your nonprofit status under the IRS, you have to conduct a community health needs assessment, and that has to include patients and especially people from underserved populations. So that needs to be part of education. Patients are not an afterthought. They're a part of everything you do. Now, I want to talk about participatory medicine. I'm trying not to make this a shameless commercial or advertisement for the society, but I think that it's very significant what we do. Participatory medicine is a movement in which network patients shift from being mere passengers to responsible drivers of their health, and in which providers encourage and value them as full partners. I kind of thought that after listening for 2 days, I thought, oh my gosh, I'm going to sound like a real radical making this statement here to this group, because I felt like what I was hearing was how we as providers have to be partners, but there was no role for the patient being a partner with you. The patient is a discipline and a member of the interdisciplinary team or transdisciplinary team. The patient, in my case, I'm a professional patient. I'm an expert in my situation, which I'll tell you about in a little bit. I view participatory medicine as patient-centered care on steroids. Patient-centered care is well below what being a participatory patient is. Now, when you become the driver, you have a responsibility to become an e-patient. And an e-patient, these are patients who are equipped, enabled, empowered, and engaged in their healthcare and their healthcare decisions. It's an equal partnership between the e-patient and the health providers and systems that support them. Now, this comes from a white paper that was done by Tom Ferguson, who died before the foundation, before the society was founded, but he is our inspiration. And I would advise you all to download this from our website. You can go to www.participatorymedicine.org and download the white paper. This was funded by the Robert Wood Johnson Foundation. And it's called E-Patients, How They Can Help Us Heal Healthcare. And you're all talking about how do we heal healthcare, how do we change healthcare. This concept of e-patients needs to be integrated into education. You can't train providers who come out and say to me, oh, isn't it cute the mother's doing research? And I've had doctors say that to me when I was basically presenting the patient as if I was a resident and saying, here are these results, here are these results, this is what the literature says, there's an option of 3 tests, I think this one, what do you think? And the response was, he had no idea what he was talking about, isn't it cute the mother's doing research? Now, patient engagement. Heard this a lot over the past couple of days. The Center for Advancing Health defines patient engagement as actions individuals must take to obtain the greatest benefit from the healthcare services available to them. Why do we care about this? Why is patient engagement important? Well, Leonard Kish has said that engaged patients have been called the blockbuster drug of the 21st century. Patient engagement is an amazing thing. What happens from patient engagement is rather shocking. The evidence shows that patient engagement benefits everyone in the healthcare relationship. The evidence shows that it improves health outcomes, it lowers costs, it improves patient care, it decreases medical errors, it decreases hospital readmissions. I could go on. And the evidence also shows that engaged patients with chronic conditions are more likely to adhere to treatment regimens. Now, I want to make a point here that you can find this information. I urge you all to get a copy of the February issue of Health Affairs. The entire issue is on patient engagement, and it is a Bible. It talks about how to evaluate patient engagement, how to encourage patient engagement. I could do a whole day lecture on what's in that, or probably a week's worth, but you need to read it, because everything that's in that journal should be in all of your curriculums. And somebody said, we don't have time to add stuff. I'm not suggesting that you add courses. I'm suggesting that you think differently. For example, when you have the history and physical class, and some people heard this in the small group, why does it have to be a medical student only doing a history and physical on, in some cases, a paid actor? You know, some places get real patients, but in a lot of cases, it's a paid actor. Why don't we get real patients? Why don't we have a PT and OT and a nurse in the room? So if the patient is someone with a disability who needs to be transferred, the PT and the OT can talk about that. If the physician, the medical student, is having difficulty doing the interviewing history part, maybe the nursing student can say, well, here's how I do it. If they're asking a question that just doesn't make sense, maybe the OT can pop in and say, well, the reason that question doesn't make sense is because he lives in a place with an outhouse. There is no bathroom. So we have to work on alternative ways. So that's not adding a class. It's not adding class for anybody. You can make an extra credit for some of the students, but the history and physicals class is there. So you're showing patient engagement. At the same time, the patient is saying, this is my problem. You're teaching context. I don't have transportation. I can't do that. I can't afford that. My landlord won't let me do this. And I teach all my OT students the Fair Housing Act. So my OT students would pop up and say, your landlord has to let you do that. It's very easy to call HUD and file a complaint. If he won't let you put in grab bars, we can do that. This is just thinking differently. It's not adding courses. Now, I want to point out, Jesse Grumman always says that engagement does not imply compliance. So you're going to have patients that say, I'm not going to do that. There are certain medications I won't take because I know what they do to me. And I just, you can prescribe them all you want. Sometimes I take the prescription because I don't have to argue so much with this particular doctor, but I'm not going to take it. Okay, my story real quick. I'm an e-patient. I have 2 chronic conditions no one's ever heard of. I'm an expert on my conditions. I work very closely with Dr. Google and Dr. Twitter. They're my best friends. I network with over 8,000 people internationally who have one of my conditions. And there are other places to network, like patients like me. My conditions, one of them, there's so few people that there's a Yahoo group that nobody ever posts anything because there's really nothing you can do about it. The 8,001, I use their protocol to treat my condition. I wanted to publish the protocol, but the person's a closed list and she won't let me. So I did my own qualitative research into the condition from public web boards, and I published that, and I presented this condition to the women's health section at APHA. I had a room full of 250 to 300 people and said, how many people have ever heard of this? One person raised their hand. At the end, people were crying, coming up to me and saying, oh my God, I think I've misdiagnosed this. I've let people leave my office with it. I think I have it. So I'm the expert. I no longer, when I had my first child, I asked the doctor, one of my conditions is medullary sponge kidney. And so I said, so what's going to happen, you know, like if I pass kidney stones, what meds can I take? Am I going to pass more or less? And he said, well, let's discuss it in my office when you get dressed. So we went into his office, and he proceeds to recite to me what medullary sponge kidney is. And I looked at him, I said, did you just read Harrison's? He said, how do you know that? I said, because I have it memorized. I give it to you. You don't have to look it up. I have to tell you because nobody's ever heard of it. And now I don't have to do Harrison's. I can give them stuff from Dr. Google and NIH online. So I, you know, and I just walk in when I see a new doctor, I say, I have this and I have this. This is how this is treated. This is how this is treated. One of my conditions, they told me I had to go to an OBGYN in the district because he's an expert on that condition. And I said, yeah, but he charges $2,500 for a visit. And I already know what my protocol is. I don't really need to see him. Can't you just prescribe the same stuff? No, I don't feel comfortable. I don't know about that. Well, here's an article I've written, and here's 5 of the articles I quoted in my article. Oh, they all, no, you have to go to someone else. So I had a doctor shop until I found someone who would work with me because I know what I'm talking about. Okay, I'm also a caregiver. This is my mother. And the reason this picture is significant is because it has to do with her history. My mother's been diagnosed with terminal lung cancer 4 times now. She doesn't have lung cancer. She never did. She worked in the Army taking Italian prisoners off of ships that were, as my mother says, it was kind of between steerage when immigrants came over and slave ships. The conditions were disgusting, and they would bring prisoners off the ships and they'd line them all up and give them the shot du jour. So my mother got TB. She didn't know it. Found a lump, the first doctor who found it. I went back and got old x-rays and found out that the lump's been there for years. He wanted to take her lung out. You know, if it was my mother, I'd take her lung out. I said, well, she's very lucky she's my mother. I got all the films. I was teaching in a medical school. I put them in light boxes and stopped every doctor who walked down the hall, handed him a ruler, and said, what do you think this is? And the consensus was it's encapsulated TB. And then I found someone who wanted to biopsy, and I had to explain to them, if you biopsy encapsulated TB, you give my mother active TB, and my father, and my brother who lives with them who's diabetic. I don't think you want to do that. She was diagnosed 3 months ago, again with terminal cancer. She loves it because she gets sympathy. So my brother's now the caretaker. I've moved. They say she's too old to give her chemo, so she thinks she's dying at 93 of terminal cancer. That's fine. Okay, transdisciplinary. What does transdisciplinary mean to patients? How do we get to transdisciplinary when we can't get one provider to talk to another provider in the same profession or read a patient's history? Most of my daughter's chart, which was about 6 inches thick, was lost by the Children's Hospital because she has 2 first names, like her last name's a first name, and it starts with SH. So people in Miami SH doesn't, you know, in Spanish, you don't have a word that starts with SH, so they've lost her chart. You can't find it. So the pediatric cardiologist has a little bit of a chart, so we went to see him one time, and he said, well, and I was so excited, he was asking a function-based question. Is she able to keep up and play with the other kids? Is she able to run up and down steps? I'm thinking, wow, he's asking a great question, and my answer was, well, she's undergoing chemotherapy for the hepatitis C that she got when they did her open heart surgery when she was a baby. She was 16 at the time. She's got fibromyalgia, she's got arthritis, she's got mild cerebral palsy, and she has this heart thing. Do you think she can keep up with the other kids? It was just such an absurd question. I said, you know, your brother-in-law, her neurologist, just saw her before we came to your office. So, you know, do you guys talk to each other? Like, you're both members of our synagogue, you both know the family. You know, do you ever, like, we're not just random people off the street. Do you ever, you know, talk about a patient? And he, you know, well, we don't have time for that, you know. So I don't know how we get to transdisciplinary if we're not getting people talking to each other within their own professions. The social contract. Is the contract with society, is it society versus the patient? Because I don't know that society has a contract with patients. I'm not sure, as you all pointed out, who society is. Is it the public versus the patient? I don't know that Consumer Reports represents me. I get Consumer Reports. It's a great magazine. I was raised on it. We didn't buy anything when I was growing up without reading Consumer Reports first. but I don't know that they represent me as someone with chronic conditions or, my needs in my community where I am. Professionalism. I think that patients view professionalism as behaviors, not beliefs. And I'm not sure what comes first, the chicken or the egg here. Because I hear patients complaining, oh, that person was so unprofessional. So they're reflecting behaviors. But again, those behaviors could come from beliefs. Professional autonomy versus patient autonomy. I wrote a book on ethics. I used to teach it, and autonomy and paternity are kind of like opposites. So if the professional has autonomy, I don't understand how the patient can have autonomy too. And I think that you need to look at what the patient wants and the patient's needs. Ethics, nobody mentioned Tuskegee. We have Henrietta Lacks. If you haven't read Rebecca Skloot's book, I highly recommend it. That's brought up a whole nother generation where people from many communities are afraid to participate in anything. A committee, they're afraid to have a test because they don't know what you're doing with their stuff, and it's scary to them. So what do patients want? They want respect. And what does respect mean? Respect means they want to be listened to. They want people to take what they want into consideration. They want information. Now, we have several people in the society who have like implantable, I don't know if they're defibrillators, there's something that reads EKG stuff, whatever it is, but they can't get the data from the company that implants it. They want to have a copy of the data so they know what's happening with their heart. That certainly makes sense. They can't get that. They're not entitled to it. It's owned by the company that implants the thing. We need to also consider context. We want patients to do something. Do they have the money to do it? Can they afford to eat the way you want? Do they live in a food desert where there's no grocery store? You send them home and say, you're overweight, you need to walk. Well, if you live in a neighborhood where there's a drive-by shooting every time you go out to walk, you're not going to walk and you're not going to have food in your neighborhood. So you can't you have to look at context. Where does the patient live? What's the time situation? Are they working 2 jobs? You've got to look at other factors. And you also need to look at privacy. Patients want privacy. They want a role in decision-making, and that role may be different with different patients, because the classic example I like to give, my dad passed away a couple of years ago. He was going to be 96. And at 94, you may have read the fraud stuff that's going on with ophthalmology, with macular degeneration. Well, I think my father's doctor was the king, because every few months he wanted to do another procedure. And my father would call me and say, the doctor said, I have 3 choices, this one, or this one. Can you look it up on the internet and tell me what I should do? You can't, my father, first of all, he couldn't see. He couldn't look it up himself because he couldn't see. Plus, he didn't use the internet. So the doctor giving him choices didn't make sense without giving him information. Now, you can give me choices, you can give me information. I'm going to go talk to Dr. Google anyway for a second opinion. So, you have to look at who you're dealing with, and you have to know who you're dealing with. Patients want a seat at your table, a seat on your board, a seat on your committees. They want to be there to help make decisions. And students need to understand that these are roles that patients have. Now, I want to also talk for a minute about the term patient, because I function very heavily in the disability advocacy world. And in that world, we hate patient, because patient means a person with less power than the provider. And just because you have a disability, it doesn't mean you're a patient. There are people who live wonderful lives who have disabilities, and they're not sick. If you lose a leg in Afghanistan, you have an amputation, limb loss, you're not sick. So you're not a patient. However, in the world of patient advocacy that Sally and I function in my role as, in Sally's role as patients like me, and my role with the Society for Participatory Medicine, people like to be called patients, but they like to be called e-patients, because that's the E is empowering. So there's a little bit of a difference. So I have my own, bipolarness about that. And I just like to say the person, the person you're treating. That seems to be a nice compromise. Now, the other thing is patients want to help. And I put up there, we have a patient, an e-patient, his name is e-patient Dave DeBronckhart, some of you may know him, and his recent book, and I'm not getting any money for this, I just like the title, it's called Let Patients Help. And I think there's a big message there that patients can help. And this happens to be the Society's Pinterest page. There's a whole bunch, it goes down further, of books. If you want to look more at the patient's view, you can Google books written by Society for Participatory Medicine members, S4PM, and you'll find all of these books, and some are written by doctors, some are written by caregivers, some are written by patients. The nice thing about the society is we treat everybody equally. Patients, caregivers, physicians, all other providers, nurses, therapists, we don't care who you are. We treat everyone equally. We also have a pledge on our site that you can take where you pledge to be a participatory patient, or at this point, a participatory physician. We're in the, we just started this, so we're kind of in the beta phase. We're going to expand it to other professions as well. Okay, so where do you find patients? People ask me this all the time. Where do you find patients? Patients are like air. They're ubiquitous. They're everywhere. They're in your waiting rooms. They're in community leaders. You can connect with online communities and social networking. You can connect with Sally. You can connect with me. You can go on Twitter. You can actually tweet. We are looking for patients to help on a committee, and you will get people responding. Yesterday, Jim Cantori from the Weather Channel was in the Midwest saying there's bad storms on the plains, and I tweeted him and said, Jim, where is it going next? And he said, it's going east, but the fun's going to be on the plains. People answer you when you tweet them, and you get results. It's absolutely amazing. There's just all kinds of things that you can find out on Twitter. This is something I saw the other day where you can go on, it's called Speaker Link. If you want patients to come speak at your facility, you can go on here and you can look for a healthcare speaker who's a patient or a provider, so just speakerlink.org. And some final thoughts. Disability is not a bad outcome or a result. It's a way of life. Someday I'd like to get NIH and all the researchers to stop saying that the leading cause of disability or this cause, people with disabilities look at it as a way of life. If you have a decrease in function, the World Health Organization measures health in terms of participation. So if you have decrease in participation, you have a decrease in health. That's something that we would love to have taught in schools, because the rest of the world is starting to teach that. So if your level of participation goes down, there's a reason. And the reason may be in the person, or it may be outside the person. It may be that you're not walking because your community's not healthy, because you can't walk outside. There's no place to walk. So that's something you may want to look into. Your desired outcome is not necessarily the patient's desired outcome. That's very important, because the patient should set the goal in what they want. So if the doctor says, I want your father to be able to see, it's like, well, unless you can perform a miracle, we can go to Lourdes or whatever, he's never going to see again. You can do all the procedures you want, you can bill Medicare as much as you want, but and I know, he's not going to see again. But what he wants to do is he wants to be able to get around his house, and he wants to take care of his own needs. So why don't you send out an occupational therapist, because you're not going to fix it. The social contract, I'm not really sure what that means, but I think the social contract means that you improve quality of life for people. I think that that's really, to me, the heart of the social contract, because we can't necessarily cure people. People are going to I have chronic conditions. The most important thing to me is my quality of life. And I did a qualitative study where I looked at a group of women who had multiple chronic conditions and said, we went through all the quality of life measures. How much sleep do you get? Do you take your medication on a regular basis? Do you eat 3 meals a day? And the conclusion was, I don't care about any of that stuff. I'm never going to get sleep. I'm always going to have pain. I have a chronic condition. I'm not necessarily going to eat 3 meals a day, and I'm probably going to be depressed some of the time. But what's most important to me, and I'm an occupational therapist, so we put everything in terms of occupation, is what I labeled the theory of occupational autonomy. Quality of life means it's very simple, the ability to do what you want to do when you want to do it. So one of the women in my group, all she wanted to be able to do, has had 32 joint replacements, and she broke her femur between her knee and her hip. And they finally, after multiple plates that broke, put in a titanium rod. She said, all I want to be able to do is I want to be able to go to church and sit in a church pew and attend a service, say hello to my friends, get up by myself, and go home. That's all. That was her goal. That's all she wanted to do. And like 20 years ago when I treated her hand after surgery, all she wanted to do was be able to get change from the grocery store. That was what she wanted. And so the bottom line, my final word to you is that patients matter. And we have to let students know that patients matter. And that what patients want is to be able to do what they want to do when they want to do it. And that we are a team. We facilitate. We're not, as a provider, the provider's not in charge. The patient's an equal member of the team. I've fired doctors. I've said to them, I can't deal with you anymore. You're not working with me. I'm firing you from my team. And I became a case manager so that I could say to a doctor, I'm a certified case manager. You have to listen to me now. I became a pain educator, certified pain educator, because I was accused of drug-seeking behavior. And the irony was that in my lawyer role, I lectured to doctors on how not to give people, how not to get in trouble prescribing pain meds. So I became a certified pain educator so I could know what I'm talking about and go to doctors and say, here's my test for genetic metabolites. I'm not doing drug-seeking behavior. I can't take those two. It's on the paper. Here's literature so you can read about what this test means, because you probably don't know. It's really new. And it shows that this is the only drug I can take for pain. And so I had to do this so that I could help my kids and myself. People shouldn't have to do that. They should be able to just work with doctors and say, here's my input. Here's what I want. What do you want? What do I want? Let's come to terms. And you've got to teach that, please. Thank you.